Just waiting for 2 more minutes. We'll start in 2 minutes. As people are just joining in. One more minute and we'll start. For all those who are part of these webinars, I just request them to put their questions, if any, to the question and answer. We have one change. The first speaker would be Professor E.S. Krishnamurthy from Chennai, India. And Dr. Linda is going to join us soon. So she would be the second speaker. So good afternoon, good morning, good evening, ladies and gentlemen, wherever you are across the globe. I'm your AOSNR President, Dr. Nirmal Surya. With me is President-elect Ferry Khan and the executive member, Jericho de la Cruz, who is a research committee member, and Abhishek, who has just boarded from Taiwan, the chair of Education Committee. We sincerely hope the Secretary Pitsan, who joins this webinar series, which was started by AOSNR, a president initiation, and today is the 8th of the series. We had the first series starting with introduction to the neurological rehabilitation, followed by the second session on neuroplasticity and rehabilitation. The third session was innovation in assistive technology for neurorehabilitation. The fourth was on cognitive rehabilitation strategies. Fifth was physical therapy in neurological rehabilitation. Sixth session was on occupational therapy for neurological disorder. And the last session on November was speech and language rehabilitation. Today we have 8 sessions on psychological aspect of neurorehabilitation. Our next session would be on 2nd of January. I hope people get a hangover, come faster and join us in the new year 2025 for the nutritional consideration in neurological rehabilitation. So with that note, I must say that these are very popular series. We had in almost every session more than 200 plus registration and people attending online. And last session, there were 30 countries, 218 people were there online, and 140 people were on the YouTube. For those who have missed out or missed out by some reason, cannot attend the today's session live, they have an opportunity to join us on the YouTube link. We are going to share you the link now. And also we will have this on our IFNR as well as AOSNR website, YouTube link. So you have all the opportunity to go through this webinar series, which is a great learning and teaching session. Also, we would request you, if you have any feedback or you are looking at any topics to be chosen for the next year's, after this series get over, the 10 of the series, you could give the suggestion and we'll look at those suggestions and come out with the new program for the 2025 March onward. So with that note, I welcome the chairperson for today, Professor Fairy Khan, who is president-elect from Melbourne, the great research lady. Can I have her slide? And she has been very active. She is the president-elect of not only Asian Oceanian Society of Neuro Rehab, but also of the ISPRM. She is the director of rehabilitation at Royal Melbourne Hospital and Peter Macmillan Cancer Center, Victoria. She has various awards. Her research goes into, huge numbers. The most important thing is she's quite linked with LMIC and doing a great work in collaboration with various countries like Pakistan, Bangladesh, and many other LMIC. So I welcome you, Dr. Perry Khan. The next chairperson is Jericho de la Cruz. I already mentioned he's the research committee head. He is from the Philippines, and he is also the clinical associate professor at Rehab Medicine, Philippine General Hospital. Is the first vice president of Philippine Academy of Rehab Medicine, secretary of Rehab Medicine, and board member, and also has got many other positions which he has been actively involved. So I welcome you, Jericho, for the 8th session of the webinar of AOSNR. And I heartily welcome our secretary, Dr. Vitsanu from Bangkok. He has been here with celebrating the Father's Day, and I'm sure he had a great party today. Could share some of the things later on. So with that note, I hand over the platform to the Fairy Khan and Jericho's to take the proceeding further.
Thank you very much, and good evening from Melbourne. Dr. Nirmal Surya, as always, does a wonderful job, and thank you very much for chairing and starting this initiative. It's a huge achievement for the AOSNR, and it's wonderful to see so many people join every week, every month, as you said. It gives me great pleasure to introduce Dr. Krishnamurthy. He's from Chennai, and we're just putting up there we are. So he's basically a behavior neurologist, which is fantastic, and a neuropsychiatrist. And you're the founder of the Buddhi Clinic, is that right? Yeah. And as you can see, his achievements are multiple. And today he's going to talk about epilepsy, why epilepsy is still a burden. And we will learn all the psychological and psychosocial elements of the burden that epilepsy causes, and generally in neurorehabilitation. Hopefully it will extrapolate it across. Thank you very much, Dr. Krishnamurthy.
Thank you so much, Dr. Khan, Dr. Cruz, and Dr. Surya, for inviting me. I'll be speaking about the Scarlet E, why epilepsy is still a burden. I'm just sharing my screen. I hope my slide is visible.
Yes, sir.
Thank you. Just going to move the imagery because otherwise it disturbs me. Yes. I have no conflicts of interest to declare. We all know that epilepsy is the most common serious neurological disease. It affects between 5 and 10,000 per 5 and 10 per 1,000 people in the community, and approximately of the 4 billion people, 50% of the world's population living in Asia, 23 million have epilepsy, with a prevalence of 1.5 to 14 per 1,000 is the statistic. And thanks to many developments in medical science, epilepsy is today eminently treatable. We have a number of options in terms of treatments. We have drugs, we have surgery, we have brain stimulation procedures, we have psychosocial interventions. But despite all this, the treatment gap in epilepsy can be as high as 90% in certain parts of the world. And I think this is something that we all need to keep in mind. And why is there a treatment gap? That's because in the developing world, we fail the 5A healthcare test. The availability of treatment, access, even if available, and affordability, especially when it's out of pocket, the acceptability of treatment. Sometimes patients do not wish to have certain treatments that we wish to offer them, and may not be acceptable to them. And of course, from the side of the practitioner and from the side of the treatment team, accountability for what we are offering and what we are doing. And 5 A's are very, very important in healthcare, and very often we don't match all 5 A's. There was this wonderful paper in 2000 called the Scarlet E, which is what I used as the title of this talk. They analyzed, this was in neurology, they analyzed 210 media stories on epilepsy. And they found that 14% of those had wrong information about epilepsy. 9% had unrealistic expectations about new treatments. 5% exaggerated the seizure risks. And in about a third of all articles, a number of inaccuracies were visible to see. And writing an editorial in the same issue, Morrill and Bentley talked about the iceberg of ignorance. And what they said was there was a role for the internet also, and today's social media, in spreading misinformation about epilepsy. And with such a widespread background of stigma, ignorance, and social disadvantage, it's not surprising that many people with epilepsy are unable to achieve their potential. And this, of course, despite the disorder being eminently treatable in a very large proportion of those affected. In this recent meta-synthesis of qualitative evidence published in 2022, the authors identified, after looking at 28 papers, 5 themes. Societal negative perceptions of epilepsy was one important theme. Internal attributions of blame leading to negative self-perception and shame was another theme. Stigma that impacts everyday life and contributes to reliance on others was a third theme. Stigma being managed through concealment and avoidance was the fourth theme. And the need for support from others, which was beneficial, but also caused dependence, was the fifth theme. Now, one of the best ways in which we can explain the impact of epilepsy is to talk about patients. And I'll talk about one such patient of ours with intractable epilepsy. When we saw him, he was 50 years old. He was a qualified statistician with a master's degree in statistics. He had intractable epilepsy for over 23 of his 50 years. And when we first saw him, 13 years before I put this case down, he was experiencing 10 or more events every month, complex partial seizures with or without secondary generalization. And these were terrible seizures. He has fallen on railway platforms. He's fallen while boarding a bus. So you can imagine the kind of trauma, physical and emotional, that these seizures were causing him. Despite his good qualifications, he was underemployed and he was doing informal work from home. Now, from a health perspective, he had therefore periodic seizures without warning, which were debilitating and caused him considerable anxiety. From a job and occupation perspective, he was underemployed, he had a low salary, he had poor job security. From a family perspective, if his wife, while less educated than him, was better employed, she was resentful that epilepsy had been concealed at the time of marriage. Like many people in India, he had an arranged marriage, and the family hid the epilepsy from her, and she discovered it after the marriage. And they both, therefore, had a very poor relationship, and she had moved out to live separately. And from a society perspective, he had no friends or peer relationships. He lived with his elderly parents, who were also his principal caregivers, and his financial support came from his brother, who was well placed and working abroad. Now, how did he overcome his problems? Within 6 months of consulting us through rational polytherapy, the seizure frequency came down to about 2 per month and was largely restricted to complex partial seizures with very rare generalization. We managed to find him a job in a hospital project as an office assistant and a statistical support worker, and he remained in that for some years. And he overcame many of his issues, including mood swings, social anxiety, and managed to build a good relationship with several of the people that he was working with in the office. Yet, he could not get back to living with his family. He remained separated from his wife and children, and he continued to live with his aged parents and continued to be dependent on them. Epilepsy, therefore, if we think about it, is an invisible disability. What makes it an invisible disability? There is a fear of having a seizure and therefore an attendant restriction in activity across the lifespan, which therefore limits opportunity for the individual. There is embarrassment and perceived stigma due to the seizures, and therefore either because the person themselves restrict themselves or the family restricts them, social, occupational, and vocational functioning does not always match age or achievement of the individual. Very often, people with epilepsy have poorer educational and occupational attainment across the lifespan and significantly diminished achievement and attendant disability, as you could see in this illustrative case of a statistician who is well qualified. There's diminished social achievement, limited peer group interactions, which you saw in him, a lower potential for marriage. He actually did manage to get married, and normal family life and relationships. In his case, unfortunately, it wasn't a normal family life or relationship. And of course, disabling epilepsy, because of all the problems it creates, also causes considerable financial burden across the lifespan. Now, when we assess disability in epilepsy, one of the challenges is that we are not always looking at permanent disability. And that, of course, happens in some people. But in a very large number of people who remain quite well between episodes of epilepsy and can function normally, yet when they have an unpredictable or a recurrent seizure, they end up being disabled, at least transiently. And therefore, to assess, one needs to look at not just bodily problems, one needs to look at activities and participation, one needs to look at environmental factors, one needs to look at personal factors that either impact positively or negatively. And the international classification for health and well-being by the WHO actually helps professionals assess people not just with epilepsy, but with a range of disorders in this way, in a comprehensive way. So this is just to remind you, apart from the disorder or disease, we look at body function and structure, we look at activity, we look at participation, and we look at contextual factors like environmental and personal factors. And if one is going to work with someone to help them be better, one has to actually look at this whole range of factors in order to make impact. Now, Germany has got some of the most widespread and comprehensive legislations to do with all forms of disability, including epilepsy. The concept, and I'm sorry if I pronounce it wrongly, Sozialgesetzbuch, is humans are disabled if their bodily functions, cognitive faculties, or mental health deviates from a typical age-dependent state with high probability for more than 6 months. Note the duration here, because that's extremely important. And if, as a result of this, their participation in society is limited. And disability in epilepsy is graded even to include rare and mild forms of epilepsy, which are considered as 50 to 60% disability, more frequently occurring milder forms without loss of consciousness, 60 to 80% disability, and frequent seizures as 90 to 100% disability. And even if the seizures stop, the person is considered disabled as long as he continues to take anti-epileptic drugs. And you are considered healed in German legislation only when you're seizure-free without medication for 3 years. So it's very, very comprehensive and very, very inclusive legislation that they have, which is why I made an example of it. And what are the privileges? There is restriction on employers with regard to employing or firing such a person, more holidays from work, the opportunity for the person to seek early pension, tax reductions and breaks, a social obligation for larger companies to employ such people who are disabled, the right to adequate work, prohibition against discrimination by anyone, the right of inquiry, and special facilities and privileges for studying with disability. So the privileges are also considerable. The WHO and the International League Against Epilepsy also urge us to look at people in a very holistic way. So they want us to look at educational and occupational functioning in the person with epilepsy, family and marital functioning in the person with epilepsy, psychological functioning in the person with epilepsy, physical health, nutrition, and medical comorbidities in the person with epilepsy. And of course, all this put together is what leads to a good health-related quality of life. And therefore, what all should we keep in mind? We need to look at school and university participation when it comes to education, and we may need inclusive classrooms in mainstream schools. We need jobs which also must leverage on skilling opportunities. In India, we have something called the Skills India program, where school leavers are skilled to actually go to work. We need, societal participation to empower the person with epilepsy, and we need to encourage social activity and interaction. We need to encourage transparency and openness. In this gentleman's case, for example, not revealing the diagnosis was one of the things that led to his marriage falling apart. And therefore, for relationships to be well, we need to encourage transparency and openness. People should be able to talk about their epilepsy to others whom they meet. And then, of course, from a financial well-being perspective, we need to be able to help everyone understand what their entitlements are. We need to be able to advocate for our patients, and we need to identify and take advantage of all possible state-sponsored schemes that can help such an individual. This is just to remind you that about 70% of epilepsy comes from the medial temporal lobe. And the medial temporal lobe is the center of memory and the center of emotion. And as a consequence, people with epilepsy have a biological propensity for depression, anxiety, and dysautonomia, all of which can be tremendously disabling. And of course, in a person with epilepsy, one of the consequences of inevitable familial overprotection and stigma is a constant dissonance between their inner urges and socially permissible actions. And what this leads to is a psychological conflict. And the presumption here is that the anxiety is so strong at the conscious level that it gets repressed and then converted into a physical symptom. And we do meet people with epilepsy in whom stress is a very important provocative factor for epilepsy. And therefore, managing stress is not just important for their overall health and well-being. Managing stress can be very important for managing the frequency of seizures as well. We did learn about learned helplessness from the post-war assembly line workers who had no control over the nature or pace of their work and used to engage in repetitive tasks for hours on end. But people with epilepsy also experience learned helplessness. They have no idea when the next seizure will strike. They have concerns that if such a seizure would come, it would leave them embarrassed in company or in a public place, and they are constantly worried about their safety and well-being. And therefore, there is an experience of constant learned helplessness in a person with epilepsy, which is a source of tremendous psychosocial stress. And then, of course, there is this whole idea in psychology of locus of control. An internal locus of control, where you feel you're in charge of your circumstances and control them, is protective from emotional stress. An external locus of control, where you feel controlled by your circumstances rather than by yourself, makes you vulnerable to stress. No price is for guessing that for a person with epilepsy, it's constantly an external locus of control, especially if they have frequent seizures, and that is another source of constant stress. One of the reasons for stigma also is that we fail to be open, we fail to talk, we fail to inquire about mood, about anxiety, about feelings of suicide, and other mental health symptoms, which are a very important part of the invisible disability of epilepsy. So it's not enough to talk about seizure control. It's not enough to adjust seizure medication. It's extremely important that we inquire, understand, and address psychosocial factors. We should never underestimate their impact on the person, And we also should not underestimate just a kind word from us, even if we are not psychologists or psychiatrists. Just a kind word, just an inquiry, just a be well message is good enough for a lot of people to carry on. And the power of that needs to be used by every healthcare worker. This review by Mulla and Sander in the British Journal of Psychiatry Open talks about the psychosocial aspects very well, and I recommend it to all of you. They point out that cognitive problems and psychiatric comorbidities often accompany epilepsy, that people with epilepsy often have to endure negative attitudes towards themselves. And this is manifested as social stigma, social isolation, and a lack of support. And they talk about the need for public health systems to invest in awareness programs to increase public knowledge and reduce stigma in order to minimize such disparities. We published a best practice model of multidisciplinary care many years ago, 2009 actually. And in this paper, we talked about how the neurologist or the neuropsychiatrist would be the team leader, the decision maker, would take a vicarious responsibility, but would work together with the neuropsychologist, with social workers and counselors, physical and occupational therapists in order to provide an integrated model of care. This was the workflow that we published at that time. And actually, to a large extent, this continues, but I'll show you that we actually have expanded the way we work. The patient reports to the clinic, is triaged by the doctor, is referred to the team for a detailed evaluation using standard outcome measures. The physician reviews the reports and then puts an investigation and treatment plan in place. They will follow up either in the epilepsy counseling clinic or they are referred for a comprehensive inpatient or outpatient rehabilitation program, which also often goes home for those people who are disabled and can't frequently come to clinic. We have expanded that, and this is our philosophy as to why multidisciplinary and multi-component care is important in patients with epilepsy, because of the very large referral gap, the very large treatment gap, and indeed the very small number of people who get the higher order treatments. We contend that advances in science are slow, and advances in science and technology take time to reach the developing world. I've talked to you about the 5A gap and treatment-resistant epilepsy, and therefore a multidisciplinary, multi-component program is much more likely to help. And integration of care, in our program, we bridge modern science with the ancient Indian traditions like Ayurveda and yoga. And integration of that nature has a huge impact on making treatment acceptable to the person. One of the 5 barriers is acceptability, and integration actually makes treatment more acceptable to people. It focuses on the reduction of suffering, better retained activities of daily life, and better retained quality of life. It also helps the family involve themselves in the caregiving of the person, and this gives families a sense of satisfaction. And this is something that's been widely talked about and published in India in relation to a number of neurological diseases, in particular dementia. And therefore, while we have anti-epileptic drugs and psychotropic formulations, we have epilepsy surgery, we have invasive and non-invasive brain stimulation methods, there is a need for us to think about physical and psychosocial rehabilitation. Many patients may require therapy for speech, language, occupational and social skills. And almost all our patients benefits from holistic care that looks at nutrition, sleep, exercise, using yoga, mindfulness, and traditional systems like Ayurveda. A good system also should be locally available and culturally acceptable, blends modern science with healthcare traditions, improves activities of daily living, improves quality of life, measures and tracks healthcare outcomes, and has an element of inbuilt client choice. Because please remember, for someone to engage with treatment, they need to choose it. And this is extremely important. One very interesting advance in science that's become a part of our non-pharmacological care program is transcutaneous auricular vagus nerve stimulation, where we stimulate the auricular branch of the vagus nerve. And this is a repeated stimulation to the auricular branch of the vagus nerve, which is an easy target. There is high treatment adherence, and the procedure is very well tolerated. Very few side effects like headache or ear pain or skin alteration have been reported with the TAVNS, and it certainly has a very huge role to play in reducing the frequency of seizures in patients with epilepsy as a non-invasive treatment modality. And I thought it's important we just talked about that briefly. And in Buddhi Clinic, of course, we combine this with pharmacology, psychological therapy, physical, occupational, and speech therapy and holistic care, all delivered as a program. And that's really the way we work right across the lifespan. I want to finish by talking about Maslow's hierarchy of needs and pointing out that, we all look for physiological needs being fulfilled, safety needs being fulfilled, love and belonging needs being fulfilled, self-esteem needs being fulfilled before we self-actualize. And I think as a society and as healthcare professionals, we have a role to work towards the self-actualization of people with epilepsy, indeed, people with all forms of neurological and mental health conditions. And with that, I'd like to thank the organizers for inviting me to do this. Thank you.
Thank you very much, Dr. Krishnamurthy. That was an excellent overview of the neurobehavioral issues related to epilepsy. I have a few comments, and if we have just a few minutes for questions, would that be all right, Nirmal?
Yeah, there is one question also.
Okay, excellent.
So Dr. E.S. Krishnamurthy. The question is, how does anxiety impact epilepsy psychological effect in neurorehabilitation?
So one of the challenges we face as practitioners is making the difference between an epilepsy event and an anxiety event in a number of patients, especially when the epilepsy is complex partial or partial. So I think that's a challenge that most of us face constantly. Anxiety is often a trigger for seizures. Anxiety causes sleep deprivation. Anxiety also, as I pointed out, is part of the medial temporal lobe complex and also causes autonomic symptoms, which sometimes can present like non-epileptic seizures. So there is this complex relationship. And then, of course, having a seizure event causes a person to become anxious. I think in terms of rehabilitation, well-managed seizures are very important, and therefore encouraging people to be treatment compliant is very important. Helping them find psychotropic agents for anxiety that are safe in a person with epilepsy, because some psychotropic agents actually can trigger seizures. So it's extremely important that we choose the right psychotropic agent to help them. And I think invariably everyone is helped by psychosocial interventions, talking to a counselor, practicing yoga or mindfulness, or learning Jacobson's progressive muscle relaxation exercises. All this can be extremely helpful. And I think therefore neurological units, and especially those that look after people with epilepsy, cannot afford not to have psychosocial support, because this is extremely crucial for the patient.
Thank you. Yes, Barry.
Yes, thank you very much. That was excellent. And we all have learned heaps from you today. Thank you. I just wanted to just summarize 2 or 3 things, and that made me think about little notes I made while you were lecturing. So firstly, I think it's really good that you talked about the intermittent nature of epilepsy. And I just wanted to remind the audience, especially all the younger trainees, that the NHS in the UK has a document published now nearly 20 years ago. It's called Long-Term Neurological Conditions, where they talk about permanent conditions like brain injury and spinal cord injury, intermittent like epilepsy, and multiple sclerosis, when it's episodic and so forth. So maybe, and that's got 11 standards that they recommend that transdisciplinary teams should look at, 7 or 11 standards that are generally, and 3 that extend to the community. And they really summarize all of the things that Dr. Krishnamurthy has said. So it's a good idea to look that up. The second point I was really impressed with was that, you're talking about holistic care, which is fantastic. So it's very personalized care, isn't it? I think neurology and rehab medicine have been doing personalized care long before it became sexy and, recommended. So we've been doing it forever. And you talked about international classification of functioning and health, and you talked about contextual factors, which include the environmental elements like attitudes of people with like families and employment and all the things you've mentioned. But it also talks about personal factors, which are very, very badly defined by the World Health Organization within this context. And it's all of those things about gender, acceptance, and the Maslow pyramid, and all of those things impact that. So maybe people should look that up too, because it will just reinforce what Professor Krishnamurthy has just said. My last comment was, it was really interesting to link the temporal lobe and the epilepsy and the anxiety and the tendency for depression and other issues. And, you talked about yoga and you talked about meditation, which is fantastic. In Australia, we don't do that as well. Mindfulness and all that work is so important. And we're trying to learn from many of our Asian colleagues and getting that into our system, incorporate that into our public health system. I was just wondering, it's very similar to almost having the cognitive behavior therapy, the CBT, like we have in chronic pain, the transformation of functional elements of the anxiety and stress into fake or pseudo seizures, or and so anyway, I just wanted to summarize those comments. And what do you think about CBT? I mean, do you think that there is an element of that could be done through the transdisciplinary input?
Absolutely. I think it's an invaluable part of the psychologist's armamentarium. And we're certainly able to help people using CBT with their depression, with their anxiety, and even to some extent with epilepsy control. In fact, at Queen Square, when I was training, we had a CBT specialist working just on the epilepsy group of patients. Who and I think they had a lot of experience in working with a particular population. So you're absolutely right. I think cognitive behavior therapy is very, very powerful and can be extremely useful in patients who are going through psychosocial stress factors.
Thank you very much.
Krishnamurthy, there is one more question, if you are able to answer that, otherwise I'll do that. Are there chances of triggering an epileptic seizure with exercising?
I'll try to answer it, Dr. Surya, but then we will defer to your very, very wide experience. I think the answer to that is, one of the things that exercising can do is trigger autonomic symptoms. And autonomic symptoms are a part of some seizure paradigms. So indirectly, perhaps, yes. There's another aspect that I think of often, that some people exercise against the clock, or some people exercise in ways that stress them out. And I have seen that lead to a seizure. So I guess it's both mental attitude and triggering autonomic symptoms are the two things I can think of, Dr. Surya.
I think you rightly put up. There is one way the exercise is good for brain health, and that is going to get everything better. But there are very few epilepsy which are known as reflex epilepsy. Like you have an epilepsy, like eating epilepsy. This person eat and get an epileptic seizure, or the reading epilepsy. So somebody reads and get an epileptic seizure. Similarly, the person who can get an exercise-induced epilepsy. So these are reflex epilepsy, which is not very, very common, but in those person, if it is there, it has to be treated and exercises has to be avoided. By and large, we all know that exercise is good for brain health, and therefore 98% epileptic cases will get benefit for that. Thank you very much for asking my comment, Dr. Krishnamurthy. Hand over to the chairperson for the next event. I welcome Teresita, the past president of Asian Oceanian Society of Neuro Rehab, and of course, our esteemed learned next speaker, Dr. Linda.
So good evening from Manila. So can I get the slide for the next speaker? So our next speaker will discuss Shadowing the Golden Path, a psychosocial support program for carers of elders with mental health needs. So she's a professor of the Department of Psychiatry, Faculty of Medicine of the Chinese University of Hong Kong. Her research interest is early detection and intervention for mild cognitive impairment and dementia, a biomarker equivalent for mild cognitive impairment and dementia, determinants of health aging, and epidemiology of mental disorders in Hong Kong. She is the past president of the Hong Kong College of Psychiatrists, past editor-in-chief, East Asia Archives of Psychiatry, council member of the Hong Kong College of Psychiatrists, founding president of the Chinese Dementia Research Association, and associate editor, editorial board of the International Psychogeriatrics. Ladies and gentlemen, let's welcome from Hong Kong, Dr. Linda Lam.
Thank you, Chairman, for your kind introduction. And I'm honored to be able to share my recent work on caregiver support and psychological intervention package. Because with more exposure, everybody probably will share with me that caregiver has a lot of stress and they need special psychological support. So let me share my slide. Can you see or not yet?
Yes, Professor, we can see it.
Yeah, you can see the slide?
Yes, Professor.
Yeah, okay, so
You can just put it on slideshow mode.
yeah, I'm going to do the slideshow. Is it the slideshow now or still the slide?
It's the presenter's view.
Okay, let me try the slideshow.
Just click on the three dots.
Let me see the should be the slideshow now.
Yeah,
Yes,
now it's coming.
yes.
Yes, it's okay now. So let me start. So this program is called the Sharing the Golden Path because a few years ago when we think of a specific program for offering psychological support for carers of elders with mainly with dementia, but also with other mental problems, we are thinking of a good name that would portray the positive impact. So that's why we use this Sharing the Golden Path, thinking that the end of life path may not be that bad, and hopefully this would give a positive image to the whole program. So for caring older people, we know that it is an integral approach that works. And when one gets older, the possibility of mental health problems actually gets an exponential increase if we take into account of the high prevalence of dementia. And caregivers of people suffering from mental disorders and cognitive disorder in old age have a lot of stress. And in this WHO scoping review, they want to survey what are the most effective and useful support for people with mental health needs. So in this scoping review published a few years back, the question is actually, is respite care more useful or psychosocial support more useful for family caregivers of the dependent older people? We know that both of them are important, but from the empirical perspective, which one would be probably more effective? So the scoping review is conducted in family caregivers of people older than 60 years of age. And the interventions that they research is respite care, psychosocial support, and technology-based intervention. And that paper was published a few years back. And we probably need to accept that technology has advanced in the past couple of years, and there may be a paradigm change. But for the this scoping review published in the ICOP guidelines under WHO, the recommendation is that psychosocial intervention should be offered to family members and informal caregivers, particularly when the care needs are very complex and extensive. and there's a lot of caregiver strain. And the quality of evidence for the publications available at that time is that the psychosocial support offer some moderate strength evidence with a strong recommendation. Whereas they look at the respite care, the recommendation could not be offered because the evidence is more inconsistent, probably related to the methodology and probably related to how much respite care differs in different localities of the world. But the message here is that we need to develop better and perhaps more structured psychosocial intervention, because if we are talking about diverse spectrum of psychosocial intervention, that could be quite difficult or have a lot of limitations for knowledge transfer. The second point I want to share with you before I go to the Sharing the Golden Path program is about a recently conducted survey on the prevalence of cognitive disorders and mental disorders in older people. It's what we call the Hong Kong Mental Mobility Survey for older people. This is a survey commissioned by the Hong Kong government, which our team conducted from 2019 to 2023. And we survey about 5,000 older people living in Hong Kong. The overall prevalence of mild neurocognitive disorder is about 1 in 5, whereas the overall prevalence of major neurocognitive disorder dementia is about 10%. So let's focus on the carer experience. For that particular survey, we managed to interview 120 something people who are carers of older adults with normal cognition. They don't have obvious cognitive decline. And 250 carers with mild neurocognitive disorder and about 70 carers with dementia. So as you would have expected, carers have poorer mental health, more burden, and also more requests for logistic help if the care recipients have higher level of cognitive impairment. And there is a big jump from mild neurocognitive disorder to major neurocognitive disorder in terms of carer burden, as well as mental health problems. But we have to note that for people with mild neurocognitive disorder, there are some carers who also feel that they have burden and stress. So in our caregiver experience analysis, we note that about 9% of dementia caregivers, the caregivers of people with dementia, reported thoughts of death or suicide ideas in the past 2 weeks. That's not a low figure. So almost 1 in 11 people, caregivers would think of better off dying in the past 2 weeks. And this suicide intention is higher in prevalence in female carers if they have depression, anxiety, and also carers of people who are more dependent and have higher comorbidity. When the care disciplines are poorer, more frail, and more cognitively more impaired, and if the caregiver is a woman who have themselves depressed or anxious, the risk of suicidal ideas would be higher. And we also note that the care burden and suicide ideas was actually mediated by psychological distress, meaning that if you have burden and you are depressed, then you have a high chance of having suicide ideas. And more importantly, when you think about intervention and psychosocial support, we realize that if the carers have a better experience or positive experience of caregiving, if the PAC is higher, then they have a lower rate of suicide ideation, even if they have moderate to high caring burden. But if they have the ability to feel that the caring experience gives them positive aspects, then it's more likely that they have less intense suicide ideas. So that's why we think psychosocial intervention should focus on positive experience, and especially in carers experiencing high psychological distress. So around the same time when the Hong Kong mobility survey for older people is conducted, we developed this Sharing the Golden Path program, which is co-developed and supported by donation from the D. Chan Foundation in Hong Kong. The concept of this Sharing the Golden Path program is that a psychological support program for carers of elders with mental and cognitive needs. And we note that caring for these elders with mental problem is actually a very complex task, as frequently these care recipients not only have mental problems, they have cognitive problems and they have physical problems. So the caring is actually very demanding and very complex. And because of the complexity and the high requirements for physical efforts and mental efforts, the positive experience, the positive feeling towards the care recipients are frequently buried under the heavy physical and psychological load. So that makes the carer burnout very easy to occur. So the approach for this Setting the Golden Path program is that we want to focus on self-rediscovery. We hope that the carer can appreciate, understand themselves, understand how much stress they themselves are experiencing, what are the physical limitations, and then from the understanding go deeper into the appreciation of the caring experience, and through the appreciation, understanding the interactions and able to cultivate. And then we revisiting, don't forgetting love, because we have a strong belief that the carers who are able to are willing to endure the caring journey actually have a strong positive feeling and emotional ties with the care recipients. Otherwise, they would just send the care recipients to the nursing home. If they keep on and they struggle to be carers, despite that there are high burden, there is a strong emotional linkage. We want to surface this emotional linkage. So the 5 component is self-knowledge, and then self-regulation. Once the person knows that they are stressed, they are emotionally tense, they need to know how to regulate the emotion. And once again, I echo Chris just now that physical and mental exercise, mind body exercise, we actually use my modest yoga movements, asanas, to help to induce self-regulations of emotion. And when the person learns how to regulate their emotions, we talk about self-efficacy. We talk about the caring journey, and we talk about how to anticipate the end of the journey, and we call anticipatory grief management in the final parts of the program. This program is we hope to be self-sustainable, user-friendly, and so that we could disseminate and train people who are interested. So the first phase of the Sharing the Golden Path program is actually a 10-session program that runs every week with a 90 minutes, 1.5-hour sessions in each session. And we conduct a open label study, pre and post study evaluation of the effectiveness, because it is conducted in the COVID time when social isolation, social restriction policy was still in phase in Hong Kong, especially for the elderly centers. So we cannot do the randomized control trial. That's why we do the pre and post study. And the program was delivered to 187 carers with their care recipients joining some of the activities. And in groups of 30 groups were conducted. So the average is about 6 carers per group. So the following couple of minutes, let me describe the session outlines. And the session has 3 components. The first component consists of 4 sessions. The first 4 sessions is knowing yourself and warming up. So we have the first session for ice breaking, introduction to the program. Session 2 is guided by the instructor, the self-rated mental and physical health. The carers needs to rate their physical health as well as the mental health, like blood pressure, body mass, grip strength, balance, ability, aches and pains, and also their cognitive function and also their mood symptoms. And then after knowing that, and they have to go through two sessions of physical exercise. Is basically mild to modest strength physical exercise, and we choose the yoga asanas, which is similar to that of the MBCT, mindfulness-based cognitive therapy, very similar. So the instructors of these programs are actually either yoga teachers or they are fitness trainers. The second component is after they learn how to do exercise, they started to learn the mental aspects of relaxation. It's active stretching, mind-body awareness, total relaxation, and mindful practice for emotional regulations. So we believe after they have learned how to regulate the emotions, we will talk about the self-rediscovery journey. There's standardized manual for each sessions of the life journey, the positive experience, how to discover the positive experience, how to acknowledge the negative experience, and reflections on burdens, responsibilities, and also peer group sharings, and we take home assignments to reinforce. So the structure is similar to that of the CBT, but it is carer focused mainly on that of the caring journey, and we do not focus on dysfunctional thoughts as the core component. Rather we put the positive experience as the main theme for discussion. So the last session is the sharing on self-help tips and feedbacks. So was the program effective? So I just want to share with you the program evaluation now. The demography of the evaluation is we have 180 carers participated in the program, mostly women, as you would expect, but we still have 24 men. The average age is 67 years, so about 60% are spouse carers and about 40% are children carers. So you could see a good mix. According to us, is already a good mix. Diagnosis mostly dementia with behavioral problems, and others with depression, delusional disorder. We have a few. The participation rate is not bad because about 90% participants actually attended over 7 sessions. So this participation is important because we understand that from regression analysis, the rate of participation is directly related to outcome. So this is the outcome. The left side of the left side bar chart shows the P-assessment clinical interview schedule score. About half, 40% of them are quite normal, but we have people who have severe common mental disorders like depression and anxiety. We have depression and anxiety not that severe. We have subsyndromal symptoms. The graph on the right side, the bar charts show that this is a post training kind of reassessment. So after 10 sessions, there is a tendency for the severe symptoms to move to the milder symptoms. Though and also the increase in the amount of people who become normal, their symptoms remitted. But generally, depression and anxiety symptoms got better in the whole group. And the pair t-test for the CISR score is statistically significant, although the effect size is still small, but is significant. So the second question that we want to explore is that would caregiver burden be reduced in dementia caregivers? So caregiver burden is very hard to reduce because they still have to take care of the care recipients. There's nothing changed with their role and responsibility. The only thing changed is how they perceive themselves as a carer. And do they get booster psychological support from the peer as well from themselves? We want to make this energy coming from themselves. So we are happy to see that for people who have depression and anxiety, not the most very severe one, the severe one on the right side, the right, furthest right did not change burden, but the one on the middle side, the baseline burden reduced after the intervention. So if you have mild depression and anxiety disorders, it's likely that after attending the 10 sessions, there is a chance for your carer burden score would be reduced. We also assess the mental well-being index because we are aggressive in the expectations that they may feel better in terms of mental well-being. But unfortunately, we did not see any significant pre and post change in the mental well-being and mindful awareness score index. Perhaps the dose of the intervention still needs further enhancement in boosting mental health and mental wellness awareness. So we also did a survey on the participants' opinion. So the question we asked is, did the program enhance my self-awareness of body and health? I think you share with me that many carers did not know that they are highly strained and did not know that their physical and mental health have been compromised. So that's one of the components is you want them to know that they are on their limits or they are not at the limits. So majority of the carers feel that this program helped them to know more about themselves. And the majority of the carers agree that this program helped them to appreciate positive experience and appreciate their emotional links with the care recipients. It's not just caring is a responsibility, it's an obligation, something that I need to do, but I don't like to do it. I do not love my relatives, but it's my responsibility, my role endowed to me, so I just carry on. We want to change this a little bit. And we also want to emphasize that there is a meaning, there is a reason for caring. Although it's not easy, we are happy that a majority think that they are willing to rediscover the meaning and reason for caring. And the program adds them energy to carry on with the caring journey, but the caring journey is very long and it's not easy to change the difficult part, but the in-person part, we hope that we can change a bit. So this finding of the Sharing the Golden Path program suggested with the context of limitation in evaluation, it is only a pre and post evaluation is conducted in COVID pandemic time, and the availability of space in a group format in the elderly centers is limited. We still think that there's the results suggest that the program, the 10-session program may help to reduce depression, anxiety, and carers with mental health needs. And we want to further strengthen the positive experience in future refinement of the program. And we also want to boost the self-practice mode. We hope to have a further enhancement of the program by adding the online support, self-support mode after the carers attend the face-to-face program. And we are now conducting the train-the-trainer workshops in Hong Kong, and hopefully can have a wider spectrum of skill transfer to people who may be interested to conduct carer support in the elderly centers. So I would like to close by giving acknowledgement. The whole list of elderly centers, there are 30 elderly centers, suggests that we have 30 groups conducted over the last few years. And each of them help us to arrange the place and arrange supporting workers and recruit staff. We also like to thank our research team members and also elder advisors and for this program. So thank you very much. I hope I will be able to share with you some of our recent work on carer support programs, how to structure the manual, and perhaps it's useful for dissemination and training. Thank you.
Thank you, Dr. Lam, for that highly informative lecture. That we have to emphasize that we have to care for the carers so that they can give proper care to our patients. And then I think you've said that based on your STEP program during your shadowing exercises is one of the key. No, you have 2 sessions on exercises.
Yes.
So
yes.
I think you have to get out of your mind, right? You have to be put yourself, you said you put yourself into a good mindset that you have to care and find the reason for why are you caring for this person, right?
Yeah.
So like for example, here in the Philippines, we have a very robust family unit. So in terms of caring for the elderly, or caring for the sick individuals or our relatives, some look it as a burden. And then you said it's an obligation rather than you really want to care for them. And getting out of the mindset of it's an obligation makes you care for the patients more. Did you agree?
Yes, I perfectly agree with that. So that's why we use exercise. Actually, it's mind-body exercise, and to help them to go into a state that they are more relaxed. And because when we talk about carer stress and carer burden, if you want in the groups, then there is a lot of negative thoughts and a lot of conflicts, negative thoughts, and because there's a lot of things that is very difficult to do in a daily caring, and especially for people with dementia who might have delusions and also temper outbursts. So that's before we talk about the psychological part, we get them to know how to relax. So that's why we use yoga, breathing, stretching, relaxation. Actually, our Hong Kong elders that were fascinated because when we quote them and said that we will teach you yoga, they will say, "What yoga is for Indian people? Yoga is for the fit young people." But they are attracted by these ideas that is teaching yoga. So actually, we have a video. But unfortunately, it's in Cantonese. One of the carers said, "Oh, it's a good opportunity for me to learn yoga. Then I know how to relax." So yes, mental relaxation, mental exercise is the key and the entry point for experiencing positive aspects of caregiving discussion.
And doctor, you also said that this person did not know they're approaching their limit already. So do you have any advice? Of course, we're doctors here, we're physiotherapists, we're caring for people. So how do you say that you're nearing your limit?
Well, actually, we
Are there
have
telltale signs that we have to say, I have to take a break?
Actually, we give them a lot of questionnaires to we actually measure the blood pressure, the heart rate, and we ask them to do the balance test and the grip strength, and also body weight. That's the basic physical check, and we take their history, and we ask them to rate for the depression anxiety scale and also the cognitive function scale. So we show them the cutoff for normal people. Now, and your blood pressure is high objectively, and your grip strength is so low, and you are physically fail. I mean the carers, and we ask them, you look at your depression score is above the cutoff. So this is how we help them to learn doing the assessment by themselves, and then help them to learn that you are on the limit. And of course, because it's running in a group, after checking, each carers actually share their experience, and that, the first time they realize that already I'm off the limits, something like that.
Yeah, we should allow the carers to breathe. Sometimes they feel guilt when you leave your family members that are sick, and then you go out with your friends or go on vacation. You feel a little bit of guilt that you're leaving them behind, but sometimes you need that space to unwind and start all over. Give yourself some space, your mental health space, right?
Yes.
There's a question in the chat box, and it says the social support role and its influence on psychological recovery in older adults.
So is it referring to
The social support role and its influences on
psychosocial
recovery, psychological recovery?
Is it referring to the caregivers enduring a carer role that they have to support despite that they're already depressed, despite that they're anxious, and despite that they have physical limitations? And this is very sad. Actually, in Hong Kong last year, we have a few suicide pacts when the victim was a debilitated care recipients with advanced dementia, when the carer who performed the suicide pact actually was the carer who were depressed. and one actually have been seeing psychiatrists. But of course, the depression is not completely well maintained. And the other was a couple from very wealthy families. And we were shocked from reading from the newspaper. And the very wealthy families have problems and barriers to psychiatric treatment. I think it happens in everywhere. So I think the social support role offered to the carers, especially for the spouse carers, is very strong. And sometimes it's so strong that they take aside their own needs and try to use all the time for performing caregiving. But then the effectiveness is not good.
Thank you very much, Professor. So I'll give you back to, are there any other questions? Okay, Professor Nirmal.
We have a question from the house. Question is the support role and its influence on psychological recovery in elderly people. Any advice you have?
I think we just discussed it, right?
Somebody has questioned this again, so you
The same
can.
question?
Yeah.
Oh,
Question by Jenny Lau, somebody from the audience.
I think we just discussed the caring support role and the influence on the caregiver. The other aspects we can consider is
Patients, she's asking.
the other aspect we can consider is from the social support from the supporting neighborhood. So if a caregiver was highly stressed and he or she is already off the limits and that he or she needs other support from the social networks, that would be very important. So that's why we want to set up peer support groups that, especially in the neighborhoods, that help them to offer peer supports. We have social centers because Hong Kong is very small. So we have a lot of social centers in almost all districts in Hong Kong when they do not need to travel far away. And 90% of the elders would be registered as members of the social centers. They can go very regularly, they can go occasionally, and the social workers try to actively seek the hidden elders who refuse to have social support. So I guess for that particular questions, you are able to actively reach out and offer additional social support. That would be very important for recovery.
Thank you very much. Thank you very much. I don't see any further question at the moment. Perry Khan, you want to say something?
Sorry. Yes, thank you so much, Linda. That was an excellent lecture, excellent overview. And we always underestimate the caregiver burden. I think in countries like where there's good family support, like the Philippines, as Jericho said, and Nirmal in India, and in your part of the world, that's very lucky. In Australia, we don't see that, with nuclear families. So the carer support is very limited. And we try and run peer support groups to support carers as much as we can within our public hospital system, but it doesn't always work. Although there are all those consumer societies, the jobs are to support the carers. But I do think that it's very under-investigated within the rehabilitation setting for neurological disorders. For example, carers with multiple sclerosis. I mean, it's devastating. The numbers are horrific. And, they don't always access services because they aren't as readily available as in Hong Kong. So I think it's a good reminder for us that patient welfare and carer welfare all are so intertwined, isn't it? Thank you.
Thank you.
Thank you.
So we come to the end of this series 8. Our 9th series will be on 2nd of January, the new year, 2025. The nutritional consideration in neurological rehabilitation. We'll discuss about importance of nutrition in recovery of neurological disorder and in the rehabilitation, and the dietary guidelines for people with neurological disorder and those with gastric tube or bag and with the other neurological disturbances. So we'll have a great session. We'll inform you about the international speakers we are looking for and select them and give it to you the full program. I thank you once again, first of all, to the both speaker. Dr. E.S. Krishnamurthy is well-renowned neuropsychologist running the most holistic rehab center, not only in Chennai, but at various parts of the country now. Is establishing this center with Ayurveda, yoga, Reiki, and of course, many other therapies all coming together. Truly multidisciplinary holistic rehab. So his talk on how the patient example was fantastic. Thank you very much. And he was the one who was instrumental in getting Professor Linda to from Hong Kong to speak on neuropsychological aspects of the caregiver and her work which she has done. So with these two, I want to thank Professor Linda, who has been kind enough. We have been, in and out for last couple of weeks, but I am thankful to you to accept it and be here well in time to deliver your talk. Thank you very much.
Thank you.
I want to thank past President Professor Joyce, who has been very much here. The Secretary, Dr. Vitsanu, has just left. He has some other commitment. And to both the chairperson, Dr. Fairy Khan, the President-elect, and Jericho de la Cruz for taking this session into a wonderful discussion. And we look forward to see you again soon in the new year. With that, have a wonderful Christmas and New Year to all of you. And please write to us for the second set of webinar for the year 25-26. We look forward to hear from you and get the feedback from you. Once again, thank you very much. Have a wonderful evening. Good night from the places wherever you are. Namaste. Thank you.
Thank you. Bye-bye.
Thank
Thank
you.
you very much.
Bye-bye.
Good night. Congratulations.